In the American healthcare system, patients are often assured they're covered, until they attempt to use that coverage and discover it is built less like a safety net and more like a trap. What they experience isn't health support. It's a bureaucratic ritual designed to delay access until all cheaper, slower, often rigidly applied treatments have been tried, not because they're best for the patient, but because they're easiest to authorize. And even then, many find the door never opens. The Affordable Care Act, ACA, was intended to fix this. It promised accessibility, standardization, and protection. On the surface, it delivered, with subsidized premiums, tiered plans, and broader enrollment. Yet, it fundamentally expanded a flawed framework nationwide. While patients may now pay premiums as low as $8 a month, they're often trapped in plans with deductibles as high as $7,800, narrow formularies, and delayed access to meaningful care. After adding co-pays, co-insurance, non-covered medications, lost wages, transportation, and administrative burdens, the affordable insurance total can easily surpass $20,000 a year, for care that might still be denied. The real issue, however, is not just in the cost but in what is structurally denied. This is where the system's deeper flaws are exposed. A growing body of effective, regenerative, and integrative therapies, including peptides like BPC 157 and TB 500, for nutrient support, and biologics, are showing promising results in accelerating healing, preventing surgery, and restoring function. Yet they are categorically excluded from insurance reimbursement not due to a lack of medical benefit, but because they fall outside pre-approved procedural codes. These treatments are labeled as experimental, not based on poor outcomes or lack of safety, but simply because they challenge the reimbursement infrastructure of a system built for volume billing, not outcome-based care. This exclusion reveals a bias in the insurance model. It is a system that prefers high-cost, reactive interventions such as surgery and hospitalization over early, preventive solutions. It is willing to pay tens of thousands for emergency care but refuses to reimburse therapies that might prevent such crises in the first place. This reactive model fails to recognize that healing can be proactive. Insurance companies deny coverage for GLP-1 medications like Wegovy or Mounjaro for obesity, a primary driver of chronic illness in America, under the pretext that it is cosmetic. The truth is these medications work too well, and their cost, when multiplied by the demand, threatens the actuarial balance of a system that was never designed to treat root causes. Patients aren't walking through a door to care, they're stepping into a maze of denials, appeals, prior authorizations, exclusions, and financial landmines. Doctors, shackled by documentation rules, billing algorithms, and coverage restrictions unrelated to medical science, become unwilling gatekeepers rather than healers. Insurance protocols demand patients fail treatments like physical therapy before more definitive measures, such as surgeries, are even considered, regardless of severity or evidence from imaging. Physical therapy, corticosteroid injections, or long-term opioids are mandated even when contraindicated by the patient's actual condition, making these treatments mere bureaucratic placeholders rather than genuine medical interventions. This isn't damage management, it's mechanical interference. Like feeding a family only oatmeal because it's cheap and filling, insurers impose rigid treatment sequences that meet basic requirements but leave patients unsatisfied, malnourished, and ultimately worse off. What is being hidden in plain sight is the calculated exclusion of therapies that are personalized, multifaceted, and biologically sophisticated, not because they don't work, but because they don't conform to outdated insurance billing logic. These denials are not always overt. Many patients are caught in what might be termed de facto denials, long delays, non-responses, or vague coverage criteria that render care inaccessible. They are functionally denied care without a formal rejection letter, worn down by an exhausting appeals process that assumes the failure of less expensive modalities is a prerequisite for healing. These delays often have lasting consequences, from irreversible damage to chronic debilitation, simply because the patient did not meet arbitrary checkboxes fast enough. Clinicians, too, are swallowed by this system. Instead of practicing medicine with integrity, they are conscripted into documentation and billing warfare. Their notes are no longer reflections of medical judgment but strategic maneuvers to pass the insurance gauntlet. They must preemptively justify innovation, defend logic, and frame treatment within language the system accepts, rather than what the science dictates. The result is professional burnout, moral injury, and a slow erosion of trust between patient and provider. Despite the ACA's attempt to ensure coverage, it has not meaningfully altered insurance companies' incentives or behavior. Instead, It layered additional complexity and bureaucracy onto an already dysfunctional system, resulting in increased administrative overhead without proportional improvements in patient access or outcomes. Coverage under the ACA too often remains nominal, with patient outcomes far removed from the intentions of expanded insurance enrollment. What distinguishes this crisis is not merely the repetition of problems we've long known, it is that we now have better solutions, and they are still being ignored. The science of healing has advanced. Our tools are more precise, our diagnostics more refined, and our therapeutic options more robust than ever. Yet insurance companies cling to a 20th century model of care access that excludes what doesn't fit the form, even when the function is superior. We are not just mismanaging care, we are actively preventing progress. Until the system recognizes that billing codes do not define medical reality, that proactive healing is not a luxury, and that medical innovation must not be left out of reach simply because it threatens the balance sheet, then patients will continue to carry insurance cards that fail them precisely when their bodies do. The trap is not just in being denied care, it's in being denied the future of care.